Welcome. I'm Dr. Ken Piper, and you're about to view a part 2 of a series of teaching and learning about you've got a lot of nerves, about the body's neurologic system. And this is part of an overall series that I'm presenting about the wonder of our bodies and the wonder within. This is part 2, and we're going to focus on the spinal cord. We want just to ground ourselves into the key part of our nervous system, although it's all integrated, so I shouldn't really imply that one part is more essential than the other. But here's our brain. The spinal cord is that white cord coming up inside the neck bones. It spreads up into key components in the middle part of the brain, and then everything is sent upstairs to that outer area where you see the convolutions, that wavy cortex. We are going to talk in part 3 about components of the brain, but today our focus in this part 2 is on the spinal cord, which runs from right there at the base of the skull, down the spine, down to the base of our spine. Now, just for review, in part 1, we talked about nerves. And every nerve has the same kind of structure and physiologic dynamics. Nerves have a cell body. Usually the cell body has little arms on it with additional connectors. There's about 12 billion nerves in the brain, and each of these little nerves connects to thousands and thousands and thousands of other nerves. But in this case, we're talking about nerves going down your arms and nerves going down your legs. The red areas are insulating cells around that long arm that comes out called the axon. So every nerve sends one long arm way down to little terminals at the end. Nerves in the legs start in the spine and go 4 feet down to your toes. Nerves in the arms start in the upper spine and go, 2.5 feet down to your fingertips. These are long nerves and vulnerable. They group together in bundles, and the bundles group together in bundles. But the nerves have to travel around muscles, around joints, and in part 1 we talked about a lot of the ways that we can have neuropathy problems, which means nerves that are damaged in one way or the other and don't work well. Motor nerves send the message down, touch the muscles, and fire the muscles off. Sensory nerves bring messages up, transmitted into the cord. And the spinal cord, and this is just an example of how one individual nerve is bundled to make a bigger and bigger package. These nerves then are bundled into additional bundles in the cord, and diagrammatically this is what the cord looks like. It's a long 20-inch beautifully encased conducting system, and inside it are all kinds of other bundles, some messages going up, some messages going down. The spinal cord, as I mentioned, starts way up at the base of the brain. The pink part is the cortex, the orange is the basal area. But you can see the spinal cord coming down from the neck, flowing all the way down. You can see big branches going off to the arms. Down at the bottom, you can see big branches flowing off. And that largest, darkest orange is a big nerve called the sciatic nerve. It's about 12 inches long, and then it rapidly divides into other branches. So all of our leg control, all of our leg sensations, all of our joint motions, everything from the waist down is dependent on those two big sciatic nerves doing their job. And the sciatic, by the way, is formed from 4 other nerves coming out of the spine that rapidly join together. There's about 24 bones in the spine, and there's a nerve exiting between every single bone. And up on top at the neck area, you can see that jumble of nerves. It's called the plexus. Those nerves come out and wrap together and then start to send their various branches. In the middle, in the thorax, you can see the nerves come out very straight, and each nerve travels on the inside of a rib. 12 ribs, 12 nerves. They travel around from the back of your spine up to the front of your chest. Down low, you can see in the lumbar and sacral area, again, the nerves pour out into bunches and then divide off. And as I mentioned, this takes care of everything in the lower pelvis and down below. The spinal cord is protected. So here you can see those nerves exiting out, and you can see the various coverings that provide protection. The outer covering is called the dura. It's rather thick tissue that extends all the way up into the covering around the brain. When we do an epidural cortisone injection, we're injecting cortisone right on top of that membrane. The nerves from the legs and arms flow in as one nerve, and then they divide. The blue are sending messages into the spinal cord to be sent up to the brain. The red are messages coming down that are going to go into the nerve and tell the muscles what to do. And inside the spinal cord, there are long columns of sensory areas and motor areas. We need to protect our spinal cord, and this is what part of what the spine bones do. So on the left, you'll see all the 24 bones stacked up. On the right is from the side shot. At the bottom is the tailbone, and we're looking at someone from the right side. You can see that nice curve at the base of the spine, and it curves back in the mid-spine and then curves another way up near the neck. Kind of a gentle S shape. That's how we're designed, and that's how we maintain a good, healthy spine with a center of gravity that comes right down from the base of our skull to our pelvis. The big bones in front there are like blocks that are stacked up, and you notice that blue, those are little discs in between. Very important. In between every bone, there's this little hockey puck. It has an outer shell and then an inner kind of jello-like high-pressure material that gives it some compression, gives it some bounce. The spinal cord is right in front of those big bones. You see those little openings there. That's where the spinal cord lies. It's protected. It sends its little roots out at every level. And that's really, really critical. The spinal cord in the middle needs to be protected. And the nerves have to exit that bony cage, and they have to go out little openings, again, in between each bone. And we'll talk about those openings in a bit, because when folks have low back trouble, as I mentioned, the most common cause is some condition causing irritation on the roots that form the big trunk called the sciatic. And the early warning discomfort of this kind of nerve problem is where the man has his hand, which is in that area of your back. So folks will say, my hip hurts, they'll hold themselves back there. Sometimes you'll feel the pain more in the wallet area, but initially it'll be in that area and down a little further. This has nothing to do with the hip joint. If you have a problem in the ball and socket of the hip joint, the pain and discomfort almost always is going to come down the front of your thigh. So the more you're in your back coming down into the buttocks area, you're talking sciatic nerve discomfort. And on the right-hand diagram, you can see that that sciatic pain can distribute itself down, and that's because the sciatic nerve, you can see it on the right, goes all the way down in these big branches, all the way to your toes. So if you have more and more problem with sciatic nerve, and I told you there's 4 nerves that join together. So if it's only the L3 nerve, the pain's more on the side. L4 is the side down to the front of the calf. L5, way on the side of calf and thigh, down to your big toe. And then the first sacral nerve. So there are some patterns that allow us to sort of tell which of the four nerve roots are in trouble. Often it's more than one. Now there are three conditions that can cause entrapment and pressure neuropathy on one of those four roots, one or more. One of the common problems has to do with these discs. And I told you that there's 24 bones and there's a hockey puck disc in between every bone. So you can see the disc, it's that white area. The outer shell, it stands out nicely. The center blue stuff is this high pressure jello-like material that gives it compressibility, gives it squishability. As we get older, the discs lose water. They dry out a little bit and they begin to shrink. And so you got 24 discs and every one shrinks 1/16 of an inch or so. And that's why all adults lose about an inch of height by the time they're 65 compared to when they were 16. The bones are still the same, but the discs dry and there's a little bit of a shrinkage between every single vertebral body. As the disc dries, the outside shell can weaken a bit or major injury can damage it, but if that outside shell tears and splits, first you get a bulging and then you get a rupture. And this is a picture of the center nucleus pulposus material rupturing through a herniation in the outer shell. And now that stuff is jamming and pushing on the nerve, trying to exit through that space. And this will cause, and you can see in the red there, terrible pain going down through the sciatic trunk down into the leg. Now these discs, when they rupture, they can do a number of things. They can rupture right straight backwards, which is a trouble because it's going to hit the main trunk and you're going to get symptoms down both legs. It can rupture to the left, it can go a little down, it can go a little back. There's all kinds of different ways, but the principle is the same, that you will grab, entrap, put pressure, and cause irritation, and flare up a neuropathy. Many of these flare-ups can be handled conservatively. In fact, 95% of people with their first flare-up of a herniated disc, we have a number of techniques that'll work and help and buy time, because many times these ruptured fragments will break down and break apart. Sometimes the disc fragment is in the right place and doesn't break apart, or it's really big and the nerve is trapped. Sometimes we have to talk about a surgical approach to decompress, to take that fragment of disc away and relieve the pressure on the nerve. So that's number one way to have spinal stenosis and cause leg pain from sciatic nerve irritation. Here's the second way. I mentioned the discs, and on the left there's a patient bending forward. You notice how the disc squishes. These discs are flexible. They can rock back and forth. So on the left side, the disc is compressed as we bend forward, and you can see the black arrow, which shows the joints in the back of the spine move apart. We call those facet joints. On the right, when a patient bends backwards, look at what the disc does. Now it squishes the other way. And look what happens at the black arrow. Now those joints slide together. So with every single movement, the discs are rocking back and forth, either front to back or side to side, and those joints are moving up and down. And as we get down in time and we abuse our back and damage those little joints, the body will desperately try to strengthen those areas. And what happens, you see on the right side, the bone reaction from an arthritic process. Some people call them bone spurs. I don't happen to like that term. Medically, it's called spondylosis. You can forget that. But it is a thickening of the bone as the body is trying to stabilize that area that's been damaged. On the left, you can see that nerve gets out pretty nicely. On the right, you can see the nerve is trapped. The bony material actually closes off the opening. So this is the second reason for spinal stenosis, and you can see this is more troublesome because it's not just a fragment of a disc that might break apart in pieces and move. This is actually heavy bone that is now driving in on the nerve. The third, and this is another picture on the top, you can see the nerve being really squeezed, and you can see the disc and facet joints a little clearer. The third cause of spinal stenosis is when the narrowing occurs right inside the spinal canal. And this diagram just shows what they call narrowing stenosis. This can happen from old injury, from thickening of ligaments that are inside the spine, stabilizing ligaments on the top and bottom of the canal. Discs can break apart, fragmentation can occur, bone thickness gets heavier, and the poor nerve can get trapped in the middle of all that. This is nasty because you're going to cut off a lot of the messages. Multiple nerves will be involved, and this can start to affect more than just pain. When one of the spinal nerve roots is being pressed and irritated, pain is one of the messages, but then numbness and tingling, dead areas can start to occur. And ultimately, if you squeeze off that nerve enough, you will get actual weakness. And spinal stenosis patients will sometimes come in and the pain hasn't been that bad, but they got numbness in their legs, and you watch them walk, and they're shuffling and they're not able to move their legs normally because the messages aren't getting through. The worse the spinal stenosis, the more difficult the therapy options become, and in some cases we have to do this. In some cases, on the left, you see that we had to actually cut that bone out, cut the top bone out to free up the inner spinal cord, and then we had to fuse it, stabilize it, and the stabilization comes, that you can see on the right, with long screws that are put, those are called pedicle screws, and then we connect those screws with metal plates. So that cage of metal is to provide stability while the bone grafting fusion that we put in heals the bone to give it strength again. Now, one last point is not all leg pain is neurologic. So someone who says, oh doc, when I walk or when I run, I get this burning pain in my leg, I have to stop and it goes away. That could be neurologic. A lot of folks with low back stenosis have intermittent discomforts. But some folks have vascular problem, and this last slide shows a all too common difficulty where a patient may have atherosclerotic inflammatory blockage either in the big artery in the groin or around the knee or below. And if you don't have good circulation, if you have arterial blockage, when you run, when you walk fast, those muscles down there will not get oxygen, and they will protest, they will tighten up, they will cause pain, and you will have to stop and rest. So we always have to keep in mind that pain with exercise that goes away with rest could be a neurologic problem in the peripheral nerves and spinal stenosis, but it could also be a vascular problem. It's a very important distinction. So our little tour of the spinal cord is over. In part 3, we'll go up a little higher and pick up the base of the brain, show you the 4 areas of the brain that I think are most important, and kind of how I've grouped them together so they don't seem so complicated. So, thank you. Glad to see you again.